So we are going to go through cases, and because it's a board simulation session, I'm going to go through the questions one by one, and then maybe towards the end, we'll go in, and some of them I'll spend some more time, but you can always write to me or meet me later on if you need, okay? All right, so shake out all your endocrine muscles and start thinking about endocrinology. The first one is a teenager with polys and amenorrhea. A 15-year-old girl presents with sudden onset of polydipsia polyuria. She has not had a menstrual cycle for 4 months. Physical examination is unremarkable. Fasting glucose is 86. AM cortisol is 18. Note that all the hormone levels, I'm not going to make you think what is normal, abnormal, I'm just going to put it out there because I don't expect you to know normal, abnormal hormone levels. So normal AM cortisol, prolactin is 21, T4 is 7.9, FSH is 3, NL means normal, so serum osm is 304, urine osm is 77, and a 24-hour urine collection was 3145 ml. Her MRI scan shows thickening of the pituitary stalk. A lytic lesion is seen in her mandible. The most likely diagnosis is, okay, how do I go to the audience response system, please? Okay, you guys are right. So the most likely diagnosis for this child is histiocytosis. The reason is that this person had, if you look back, had the key is the polydipsia polyuria, amenorrhea, but look at this. The serum osm is inappropriately concentrated with almost like water urine. So that's what's telling you that this kid has DI. And plus the lytic lesions in the mandible tells you that it could be histiocytosis. Okay, moving on. A 9-year-old boy has grown 3.2 centimeters in the past year. So which test is not helpful? A random growth hormone level, a random IGF-1 level, C, a post-exercise growth hormone level, and D, growth hormone level obtained 1 hour after ingestion of 0.2 milligrams of clonidine. Yes, you guys are all endocrinologists. So random growth hormone level, not useful because growth hormone is secreted in a pulsatile fashion, and hence, when you get a random growth hormone level on anyone, it's not going to be useful to you. Our IGF-1 level would be useful. Post-exercise, maybe, but 1 hour after clonidine is our growth hormone stim test, which we endocrinologists do. Next question. 8-year-old female with concern for short stature. Mom noted her to be shorter than her peers in class photograph. Negative review of systems. Her weight was 21 percentile. Height was Z-score less than was minus 4.2. Normal arm span and upper to lower segment ratio. And the skin was pale looking. So this is, remember what I told you about, workup of short stature. Bone age was 4.5 years at chronologic age of 8 years, so this is delayed. CBC was normal, chemistry was elevated, LFTs, normal CRP, TSH was 883, free T4 was 0.1, and I have the norms there for you. Celiac screen showed an elevated tissue transglutaminase A, and a karyotype was pending. What would be your next step? Refer to Peds GI, start levothyroxine 12.5 microgram per day, start levothyroxine 50 microgram per day, or refer to Peds Endocrinology. This is a case that came to me just a month ago. Okay, so basically I put this here so you guys could all think. So the diagnosis you guys all got, this is hypothyroidism. I know I put the trick there of the 12.5 versus 50. That was for a teaching point. It's because if you start someone who's so profoundly hypothyroid with a 0.1 free T4 all the way to 50 microgram, which is full replacement, they're going to suddenly feel hyperthyroid and they're going to feel sick. So you start them slow and raise them up. Dr. Kim told you about the newborn where you start high, but if somebody's profoundly hypothyroid a little later in life, you want to start slowly, but not too slow, but slowly and move up. And yes, you can always refer, but you can also take up the phone. You can start the thyroid and say, hey, doc, did I do the right thing? Okay, now this kid was very interesting because the LFTs were elevated, that you can see with hypothyroidism. Also, the other autoimmune was positive. The celiac was positive. Okay, so this kid actually had a scope and had celiac disease. And as of last week, this kid had... and this is not an audience response, so I want a hand raised, see if you're awake, okay? The GI doctor actually called me on Friday and said, hey, I saw some white patches in the esophagus when I did the scope. Now what are you thinking? What could be the diagnosis? One could be, I don't know, let me think. Could be, can anyone just shout out the answer? What are you thinking? APS, yeah, autoimmune polyglandular syndromes, because mucocutaneous candidiasis can be seen in the esophagus, so the danger you're thinking about is adrenal insufficiency in that kid, okay? So she actually had a cortisol stim test this week. All right, next case. A 3-year-old boy is noted to have pubic hair, 6 cc testes. Remember I told you puberty is the start and what is the size of the testes. Adult body odor and penile enlargement. And you gave Lupron, which is the GnRH agonist, and blood obtained, which is the GnRH stim test, showed LH pubertal response, TSH was normal, HCG was less than 5, and DHEAS was normal. So the most likely diagnosis is idiopathic central precocious puberty, hypothalamic hamartoma, dysgerminoma, craniopharyngioma, or late onset congenital adrenal hyperplasia. Okay, you guys are all right. Now, this could also be hypothalamic hamartoma. So sometimes you can, that's one of the tricks to this question. I'll come back to that. But why isn't it late onset CAH? He's got the hair. It's not late onset CAH because his testes are bigger. So this is actually precocious puberty. If it's late onset CAH, he'll only have hair, but the testes will be small. Okay, now dysgerminoma, I didn't give you other things there, talking about, if he's had other pituitary problems, that's usually the clues for the other ones. Hypothalamic hamartoma could be the cause of idiopathic CPP. So it could be that or that, but your most correct response is idiopathic central precocious puberty. Okay, next one. A slender 9-year-old boy presents because of concern about the size of his penis. His height is at the 75th percentile for age. Phallic size is 4 centimeters long. And testes are 1 cc each. He cannot identify the odors of coffee or garlic. So, what does this guy have? He can't smell his mom's cooking. So that's the way you ask the question. He has an androgen receptor defect, genetic defect in LH beta subunit, congenital adrenal hyperplasia, 2-3 beta, or lacks GnRH pulse generating cells in the hypothalamus. So that's your answer right there. Yay! So he has Kallmann syndrome, because the clue is the inability to recognize the odors. Now, Kallmann, you can argue, or can also be normoosmic, but usually when they're asking you on the boards of someone who has delayed puberty or lack of puberty or hypogonadism, and they're talking about smell, just think about Kallmann. They're not asking about anything else. All right? Good job. Okay. 14-year-old girl has had type 1 diabetes for 5 years, recently experiencing hypoglycemic episodes in spite of reducing her insulin doses. She's 14, so she should be going up on her insulin. She's now only receiving 4 units of glargine in the morning before breakfast, and fasting lab studies show a C-peptide level that's less than 0.2. That means undetectable. Free insulin was 54, glucose was 42, and a cortisol was 24. So basically what we're asking is response to hypoglycemia. Most likely cause is functional insulinoma, Addison's disease, surreptitious insulin use, perirenal mesothelioma, or remission of type 1 diabetes. So in insulinoma, the trick here is the C-peptide. Okay, so remember, if your C-peptide is the endogenous insulin, so if your C-peptide is undetectable, that's your normal body response to hypoglycemia. This kid's C-peptide is undetectable, but why is the insulin high? That's because of surreptitious insulin use. Okay, so next question. The 12-year-old girl presents because of acne, hirsutism, and secondary amenorrhea. She experienced menarche at 9 years of age. Mother remembers that she had pubic hair when she started kindergarten. So lab studies 1 hour after injection of cortrosine, so this is what we call an ACTH stim test. We give it to see what the adrenal hormones are doing. And it shows a free testosterone of 11, which I put in parentheses as normal. DHEAS is 3200, which I put in parentheses was high. And a 17-OHP of 1682, which was high in parentheses. So the most likely diagnosis is rhinoblastoma, PCOS, Cushing's syndrome, adrenal cortical adenoma, or late onset congenital adrenal hyperplasia. Yep, you guys got it right. It's because with a PCOS, you can see sometimes, but you will not see the increase in 17-OHP. That's what's telling you. You will see an increase in testosterone. That's seen in PCOS. Adrenal cortical adenoma, you will also see the testosterone high. Adrenal tumors classically just push out every adrenal hormone that they can. They have acne, and every hormone in that pathway is up. So you're only seeing some, especially that 17-OHP. They want you to think about late onset CAH. Next question. 16-year-old girl has breast development since age 10, has never menstruated. She denies sexual activity. Her breasts are 10 stage 5 without galactoria. Pubic hair is absent. She refuses to allow a vaginal exam. So, which of the following hormones is most likely to be elevated in this girl? Testosterone, prolactin, FSH, TSH, or 17-OHP? It's testosterone. And that's because you're thinking androgen insensitivity syndrome. Okay? The reason is requires a little bit of thought, because if you think about it, she has breast development, never menstruated. She's not allowing you to look down there. So you can't even tell if you have palpable testes or not. So that information is missing for you. So she has breasts that are 10 stage 5, like Dr. Hayder said. Those girls who have no hair, because they're making testosterone, but their tissues are not responsive to it. So they actually look physically female, but they're actually male. And when you examine them, you will find palpable gonads in the labia. So that's what that one is. So it's not prolactin because there's no galactoria, okay? And FSH, probably not high because, you're talking about good, breast development. TSH, there's nothing there to tell you there's a thyroid hormone problem there. And 17-OHP, usually you will have pubic hair. Okay. 9 and 10. 13-year-old honors student presents because of a lack of breast development. Pubic hair has been present for 1 year. Parents are of normal stature and had normal pubertal development. Her height and weight are both below the 5th percentile for age. Physical exam shows tanner 1 breast in a 13-year-old, tanner 3 pubic hair, and upcurving fingernails. And so remember we talked about measurement. Which of the following hormones is most likely to be elevated? Testosterone, prolactin, FSH, TSH, 17-OHP. FSH, this is the case I was telling you about. My mosaic Turner patient who they thought was short. She was high functioning, so and I sort of gave away the answer to the next question, but I actually didn't give it all away, and I'll tell you why. Now you tell me which kind of Turner this patient has. Okay. I know you're thinking mosaic Turners I said least likely to be found in this patient. Ring X chromosomes are usually found with cognitive differences. So all the rest of them, they can have normal. That's why I said she's an honor student. So, that was sort of the trick there. The Ring X chromosomes with mosaics usually have some intellectual disabilities. But you're on the right track. Okay, 11-year-old boy has type 1 diabetes for 5 years. He does his own blood glucose tests and gives his own insulin injections. Which of the following changes in his management should not occur as he enters puberty? Should not occur. Okay, yearly ophthalmology exams, yearly urine albumin, increasing the dose of glargine, decreasing the total daily dose from 0.9 to 0.8. Okay, you guys are right, because puberty, your insulin dose should go up. Now, we are going to go to growth charts now. Okay, so this growth chart most likely represents a boy with Crohn's disease, growth hormone deficiency, precocious puberty, Prader-Willi syndrome, or RTA. And I'm going to actually maybe I'll show you the growth chart for longer. Okay, so it is growth hormone deficiency. Now you can see that this child had continued increase in the weight, okay, steady, but over time he's gone down. Now, you could argue of these choices, if they had given you Cushing's, then you're sort of really confused there because the weight is going up and why is the height going down? But of these choices, remember in the boards, it's of the choices that are there. Of the choices that are there, Crohn's, well, the weight shouldn't go up. Precocious puberty, he should not be decreasing in height velocity, he should be getting a growth spurt. Prader-Willi, they shouldn't be doing this growth deceleration. RTA, both the weight and, they should have some failure to thrive there. So it looks more like growth hormone deficiency. So look at the relationship between the weight and the height. With the next one, I'll actually keep the growth curve on for longer. So this one, what do you think about number 13? This growth chart most likely represents a boy with growth hormone deficiency, hypothyroidism, delayed onset of puberty, or celiac disease. So I'm going to go back to the growth chart here and show you that it's got the, you have this weight going up and the height actually reaching up there. So we're asking about growth hormone deficiency, hypothyroidism, delayed onset of puberty, or celiac disease. Okay, so I agree that this is delayed puberty. So this is your classic late bloomer that we were talking about, where his weight is good. I didn't put a mid-parental height there, but if you did, he's reached his normal height eventually. But look at that. His peak growth velocity is right here. His peak growth velocity is about, 16, about when he's in high school. So that's much delayed than other peers. So that tells you that this guy has delayed puberty. So he reached his normal adult height right here, so that's why he has constitutional delay of growth and puberty. So in this case, if the other question was, what's the next test you would do a bone age. Okay, because your bone age would be delayed in relation to the chronological age for this patient. And they may ask you, there's a family history of delayed puberty. Okay, so next one. So look at this one carefully. This patient, this growth chart most likely represents a girl with acromegaly, exogenous obesity. I'm reading out the choices so you can think about it with the growth chart, and then I'll show you the choices. Acromegaly, exogenous obesity, precocious puberty, Cushing's syndrome, or hypothyroidism. Those are your choices. And if you go back here, you can see that the weight continues to go up, but look at that decrease in your height right there. So, what do you think about these choices? Okay, you guys are right. So hypothyroidism. Now there's been a little bit of confusion between Cushing's and, some people are thinking, could it be precocious puberty? I think these are good thoughts. So let's think about this a little bit. So if this was if this is exogenous obesity, B, then your height will actually be up. Remember Dr. Hayter said with exogenous obesity, the growth, high insulin actually acts like a growth factor, so these will be tall kids if they're just obese. So this is definitely not exogenous obesity. Acromegaly, it's not, because acromegaly, you'd have a high height. Now, precocious puberty, you would see a growth acceleration, not this. You're not seeing any growth acceleration here, and hence, that's why it's not precocious puberty. You could say, hey, if I saw growth acceleration here and then it went down, maybe that could be. But you're not seeing the growth acceleration, and hence, you don't just stop growing. You first have to have your growth spurt. Cushing's disease, well, you could argue it is a tough call, but this happened over, so many years, and it actually went all the way down here. So, and it could be either one, but I think this goes more in favor of hypothyroidism. I'll show you another one I think I have another one with Cushing's disease that I can try and show you to see if you can catch the difference in the next few charts. There might be one. So this one, okay. So this chart, you see, what do you think this kid has? And I'll show you the choices. It is Cushing's, growth hormone deficiency, precocious puberty, and renal tubular acidosis. And when you go into this chart, you're seeing that there's an increase in weight, and along with the increase in weight, there is a growth failure. So these are your choices. Yeah. So when you go back, look at those two growth charts here. Now this one, you can see that at the time the weight started increasing, that's exactly the time the growth deceleration started. So it's concomitant with that. So it's not like one, it's going together. That's usually the hypercortisolism causing increased weight or continued weight gain with decrease in the height. Whereas if you see the other one, this one, though she's always been up here, there's no acute increase, and this is just something that started around here. So it's not a concomitant increase in the weight while there's a height deceleration. Okay. And why isn't this growth hormone deficiency? We just went through the previous one. No, this one we just went through. So why is this not growth hormone deficiency? It's because, I'm saying that over time, 15, playing with these two here. So you could argue, well, could this be growth hormone deficiency? It may be, but at the same time, you can't ignore this increase in weight with exactly the same temporal relationship of the height deceleration. And that's why it goes more with Cushing's than with growth hormone deficiency. Okay, I think, yeah. So this one has, as you can see, the weight and the height relationship. Again, look at the temporal relationship between the two. And the choices in this one are Crohn's, growth hormone deficiency, precocious puberty, Prader-Willi syndrome, and RTA. Yeah, you guys got it right. So again, the same thing. You have the temporal, You have the temporal relationship between the weight, this is your classic failing to thrive here, just not going up, and then this is lagging right behind that. So this is classic of your Crohn's disease. Okay. So remember so why is it not growth hormone deficiency? With growth hormone deficiency, you would not be able to explain this portion of the curve. Why is the kid not gaining in weight? Because that's going against growth hormone deficiency. Why is it not precocious puberty? I would say usually in precocious puberty, you're not just going to see this. You're going to see that growth acceleration first, and then a static of the growth. Why is this not RTA? Well, in RTA, you wouldn't see this absolute flattening of this. You might see a more gradual one or a more chronic failure to thrive. This seems more like an acute deceleration in growth related to the height, to the weight. Okay, so question 17. 11-year-old male feels hot all the time, complains of palpitations, he's anxious, he lost about 7 pounds in 5 months. His heart rate is 150 per minute, 136/80 blood pressure, free T4 is 6.3, normal is 0.5 to 2, TSH was less than 0.1, the normal is 0.5 to 5.5. So the most likely diagnosis is anxiety, hashimotoxicosis, toxic adenoma, Graves' disease, or MEN2B. Okay, so the reason it is anxiety, obviously you're not going to, the exophthalmos gives away the diagnosis. So you're only going to have exophthalmos in Graves' disease. You are not going to have exophthalmos in hashimotoxicosis or toxic adenoma. The Graves' disease, the exophthalmos is because of that increased tissue behind the retroorbital tissue caused by the TSH and TSI, and that's why you see exophthalmos in Graves. So if they give you a hyperthyroid picture, which is classically hyperthyroid here, and they give you exophthalmos, it could be Graves only. Okay, it can't be MEN2B with that's just therefore to confuse you. So the same question. So he was treated with atenolol and methimazole. 1 week later, mom reports a generalized raised rash. What would be your next step? Yep. So when you treat with thionamides, I'm not going to go over the treatment of hyperthyroidism because that was already covered. The thionamides can cause a lupus-like reaction. So you have to be very aware that it can cause rashes, it can cause agranulocytosis, increase in LFTs. So if a patient is on these medications, then you need to stop it and then try to decide, what the rash could be. So you wouldn't stop the atenolol because that's helping his heart rate. I think first step, you could do all of these, but you would first stop that methimazole, and you would not stop that. Lugol's iodine is a way to quieten down that thyroid if you were planning for surgery. You could go for radioactive iodine therapy, in which this patient actually did that, where this rash came, mother called in the middle of the weekend, we stopped the methimazole, we arranged for radioactive iodine therapy and treated the kid. And it's not an allergic type rash that'll go away with antihistamines, so you can't treat it with antihistamines. Okay. So a term infant was born with ambiguous genitalia. No testes are palpable in the genital area. Pelvic ultrasound reveals a uterus. Which of the following is most likely to be elevated in the initial blood test? 11-deoxycortisol, deoxycorticosterone, 17-hydroxyprogesterone, cortisol, or sodium? Okay, good. So this is a classic picture of the CAH in the newborn period. What you're looking at is the absence of testes. So whenever you have ambiguous genitalia, don't panic, just examine and say genitalia present, asymmetric or symmetric. That's your first question. The next thing is, can you palpate something or not palpate something? That'll take you to two different directions. If you can palpate something, that means it's an undervirilized male, most likely. If you can palpate something, which in this case there are no testes palpable, then it's a virilized female. In a virilized female, what's the most common cause? It could be a CAH. If it's an undervirilized male, it's a whole different way to think. It could be androgen insensitivity. Is there, something else like a 3-beta? All the more rare forms of CAH could also be possibilities. But those are the ways you would approach in your delivery room to first feel symmetric or asymmetric, testes palpable, testes not palpable, and then you can go down that pathway. If I had said the kid had hypertension, then you would think about the 11, because when they're saying hypertension, they're always asking about 11. And your cortisol is going to be low, your sodium is going to be low, not elevated. Okay. An adolescent female complains about her tall stature. On physical exam, you notice some nodules on her lips and tongue. She has a history of severe constipation. No other family members have similar problems or findings. So what is your next step? Obtain a RET mutation analysis, examine patient's parents, obtain a prolactin level, or obtain a TSH level. Yep, you guys are great. Yeah, you can examine the patient's parents, but at the same time, this could be your index case. And so, I would say the next step would be to get the RET, and then you can get the parents in. So remember, this is next step. Both answers are correct, that you do want to look at the parents too, but what's your next step? You would send the RET mutation analysis, because you're thinking about MEN. This is a question on MEN. So MEN1, remember, is all the Ps, the pancreas, the pituitary, the parathyroid. And MEN2, there's 2A and 2B. And 2B is the one where they are marfanoid, they have the neuromas, the medullary thyroid cancer, and the pheochromocytoma. So that's MEN2B. Okay? So you can have pheo without MEN. Remember that. So if you have, I had a kid, I have to tell you about this one case, Dr. Sabella. Just excuse me for this one. Recently, I saw a 16-year-old who came in with type 2 diabetes. He was obese, and he came into clinic because he was just not testing. He was in college, not testing, he was gaining weight. We were just on his case to test, to take his medications, but his blood pressure was like 160 over 100. And, it wasn't just anxiety. And he actually had a fear. So I bring that up to say that there are more causes. Don't just focus on what's in front of you. Just also look, what's the cause of hypertension? We were also focused on you're not taking your medicines, you're in freshman year of college, you're not doing, you're not taking care of yourself, or you're anxious. But if there is true hypertension, think beyond, and it may not be MEN. It could be just an isolated pheochromocytoma. Okay? All right, all the best for your boards, and don't be scared of endocrinology. You just have to be logical with endocrinology. That's actually all. And please don't hesitate to email me if you have questions.